All right, the first module we're going to talk about is the Introduction to Child Health and Pediatric Nursing. And this just kind of goes over some general ideas about pediatric nursing. It talks about some different roles that pediatric nurses can play. It does focus on wellness and that concept throughout pediatric nursing. We're going to talk about Healthy People 2020. We're going to talk about morbidity and mortality. We're going to talk about some legal and cultural aspects of pediatric nursing, and of course the good old nursing process. These first few slides we're going to go through, this is just nice to know information. I'll let you know when we get to the point where you really need to take some notes. This is more historical information about pediatric nursing. The historical definition of health is the absence of disease. It's measured by two things called mortality and morbidity, and we're going to talk about both of those. And again, the shift right now is to focus on disease prevention, health promotion, wellness, kind of the things you learned about in health promotion back in J1. Here's the definition from the World Health Organization about health: a state of complete physical, mental, and social well-being. Sounds very zen, doesn't it? All right, some just history. Again, we're going to go through this pretty briefly. Kids used to be viewed as property. There wasn't really a lot of focus on child health and wellness in children. But by the end of the 19th century, some things scientifically came along: milk pasteurization, immunizations, things like that really focused on child health. The 19th and the early 20th centuries, again, the advances in science and in prevention, about nutrition, sanitation, new drugs were invented, so all of those increased the healthiness, if that's a word, of children. Towards the end of the 20th century, we have some new antibiotics, new vaccines to prevent communicable diseases, so even more advances to increase child healthiness. Some focus of the national and international organizations. The big thing right now: child trafficking, violence and abuse, child labor. All of those things have been a focus to protect children's rights. This country, you don't see a lot of that, but in third world countries, you see a lot of child labor, things like that. Lots of orphan children in those countries that are, the adult population is wiped out either by HIV or by when in Haiti, was it an earthquake or a hurricane, wiped out a bunch of adults, and so there's a big population of orphan children in parts of the world like that. I just thought some of this information was interesting. WIC was invented or put together in 1966. The FMLA, which has become really popular now, 1993. Head Start was in 95, and CHIP. I can't believe CHIP's been around 20 years. So the Children's Health Insurance Program, which was kind of a spinoff from Medicaid, has been around 20 years now. All right, we're going to skip through that question, and we're going to skip through this information. Again, this is more just history of pediatric nursing. Now, Healthy People started out in 1979 as the Surgeon General's report, Healthy People. Healthy People 2000 was the first one I remember, and then there was 2010, and now there's 2020. And again, it's a focus on wellness, disease prevention, etc. The overall goals are to eliminate disparities, improve the health of all groups, especially children, create physical and social environments that promote good health, promote healthy development and behaviors, eliminate preventable disease, more prevention focused than anything. All right, so in your reading, I think I started your readings on page 13. This is actually, I believe, on page 10. So I do want you to know the difference between mortality and morbidity. Mortality is the number of individuals who have died from a specific cause. It's usually represented in per unit rates in per unit of population, like 1,000, 1 in 1,000. That's mortality rates. Infant mortality is used as an indirect measure of the general health of a population. You hear a lot about infant mortality. Morbidity, on the other hand, is the presence of a disease. So the prevalence of a disease or degree of disability. Comorbidity means, do they have, like if they come into the emergency department with respiratory difficulty, do they have any comorbidities? Will they have asthma? Will they have cystic fibrosis? Those are all comorbidities. High blood pressure, diabetes in an adult, comorbidities. And again, that's presented as a rate of unit of population. So I do want you to go back and do the reading on morbidity and mortality. And I'll show you where that is in the chapter. All right, and then I talked about infant mortality. Infant mortality and neonatal mortality has really dropped over the past 60, 70 years. This is a very interesting slide. This is causes of hospitalization in kids in 2005 and 2006. So this kind of tells you what kids are in the hospital for. Therefore, that's what you're going to see the most of when you go to the hospital for your clinicals. You can see that the younger age groups, respiratory is a big, huge player, always is. As they get older, like in the age group 10 to 14, you get a lot of psychological diagnoses, hospitalizations for, opposition defiant disorder, a lot of psych patients at that age, and the age 15 to 19 age group as well. The respiratory incidence goes down, and the more psychosocial admissions go up. Causes of death. Now, each week when you do your developmental assignment, you're going to be asked one of the leading causes of death of that age group. And here are your answers. Developmental genetic conditions in the infant age range, premature birth, and SIDS. Those are big ones. The rest of the groups all have accidents as probably the number one cause of death. Interestingly enough, the age 5 to 9-year-olds have cancer as the second leading cause of death, or one of the top causes of death. And then as kids get older, suicide becomes a player, and homicide. All right, some philosophy of pediatric nursing. Now, I want you to remember one thing about pediatric nursing, and I've talked about this already, even in the intro video. Focus on the family. So it's family-centered nursing. You have to include the entire family. If the child is old enough to participate in this care, of course, you focus your questions and things to him or her, but include the whole family, okay? And make sure that you adapt for their culture if need be. And we're going to talk about, there's a really good table in the book that talks about different cultures and beliefs in different cultures, so you can kind of put those in the back of your head when you're dealing with a multicultural clientele. You'll have some idea of what to expect. Atraumatic and therapeutic care. We try not to poke and prod on our kids a lot. You'll find that this is not a clinical where you're going to get to do lots of procedures. If we can get away with not drawing blood or starting an IV, we do. If we can get away with not cathing a child for a urine specimen, we do. So we try to be very non-invasive and do things atraumatic. And of course, we always use evidence-based practices. That's a fancy name and a cooler name for research. Some characteristics of pediatric care: continuous, comprehensive, coordinated. There's many different team members on a care team for a pediatric patient. You have child life, you have maybe respiratory therapist, you have social work, you have discharge planners. So there's a lot of coordination that goes on for the pediatric patient. Of course, family-centered, compassionate, and culturally competent. Roles of the pediatric nurse: it's your job to be an advocate for the patient. Okay, you have to be a care coordinator. You have to involve all members of the healthcare team in the care for the pediatric patient. So it's more than just doing stuff. It's more than just taking vital signs. It's more than just doing assessments. You've got to be a lot of things to a lot of people. One of the biggest things I think with the family is an educator. There is a ton of patient teaching involved in pediatric nursing. So care plans as far as patient teaching, you'll experience a lot of those. Here we talk about educating families. What are you going to educate families about? Well, you're going to do developmental appropriate safety, vaccines, symptoms that require healthcare visits. If you work in an acute care setting and where you're discharging a patient, you need to make sure that the parents know when to bring that child back, when not to bring that child back, what to look for to indicate that his condition might be worsening, etc. So again, lots of teaching. We're going to skip right through this. This is a good old nursing process. Nursing process never goes away. We even use it. I work in the emergency department down at Cook's, and we use it. Not really, we don't sit down and write out the nursing process, but this is what we do. We assess a patient. Say a patient comes into the ER with difficulty breathing. Okay, so we're going to get our nursing diagnosis. What is our nursing diagnosis? Ineffective airway clearance. What are we going to do? Well, if it's an infant, we're going to suction their nose out, or we're going to give them a breathing treatment. That's what and what is our breathing treatment going to do? It's going to open our airways. So then we give our breathing treatment, and you always reevaluate anytime you do an intervention. So you go back and listen to their chest after they finish their breathing treatment. You do it as a nurse. You don't necessarily write it down that you do it, but that's how you practice nursing. All right, some ethical principles. You need to know these definitions. Autonomy. You do have some autonomy in nursing. You make some decisions. Other things are guided by the physicians or the care providers. Beneficence, that's any action that will benefit others. Non-maleficence, that's to avoid causing harm. Justice, veracity, telling the truth. And fidelity, keeping promises, maintaining confidentiality. Good old Hipaa. All right, we're going to talk a little bit about culture too here in just a few minutes. Do make sure that you take that into account when you're providing care for your family. Not every family will respond to care you give the same way, just based on their cultural and their beliefs. All right, some legal things about pediatric nursing. There are some differences when it comes to emancipated minors, etc. That's explained really well in the chapter, and I'll show you exactly where when we get there. But let's talk a little bit about informed consent. The decision maker, whoever signs the consent, has to be of legal age in that state. So that varies from state to state. Information that you give, remember I said, or at one point we talked about 5th grade reading level. Everything that you give to the parents or to the person that makes the decisions needs to be at a 5th grade level. The decision to participate must be voluntary, not coerced, not forced, not influenced in any way. You can witness an informed consent. You are not the one that explains the informed consent, okay? Your responsibility is to make sure that they understand what they're signing, okay? So that is your responsibility. Not your responsibility to explain the risk or the benefits. That's the physician or the caregiver, or the physician or the care provider, nurse practitioner, etc. Okay? You're just witnessing the consent process. Sometimes they ask for assent. If a kiddo is over 8 years old, they ask for their permission. Like my son is in a study and they draw his blood once a year. He doesn't have to give consent, that's me, but he is asked to give assent that he agrees with the process. So he signs a form that he says it's okay, and then I sign consent for him to have his blood drawn. All right, here's some special considerations. All right, if kids do not live with their parent, there may be some differentiation between who signs informed consent. If they're mature or emancipated minors, and we'll get that definition in here in just a second. Parental consent after divorce, usually there is a parent that's appointed, the person that can give consent. So divorced families sometimes can be a little tricky. Consent for organ donation, you have to take into consideration a lot of things when you're talking about organ donation. A lot of people have to be on board, consents have to be signed, etc. Skip down to psychiatric and reproductive health services. There are some situations where police officers can bring in children if they are considered, if they bring them in on a mental app, that's what it's called. They can bring them in, and we've had patients come in handcuffs being brought in by the police because they were dangerous to, they were going to harm themselves or harm others. So that is a form of kind of consent. Reproductive health, if someone is seeking out care for being pregnant or a sexually transmitted disease, they can sign their own consent. All right, and then this is just some information about pediatric assent. We kind of talked about that already. Advanced directives, they can apply in children in a pediatric setting as well. Hipaa. Okay, we talked about Hipaa probably, well, we may not have talked about it yet, but I'm sure that you've talked about it ad nauseum in all of your other courses. Be aware of everything HIPAA related. Big time fines can come with HIPAA violations. Log off when you leave your computer. Don't leave the hospital with your patient's information. Don't talk about your patient in the elevator or in the cafeteria. Never know who's listening. Don't take pictures of your patient with your phone. Don't post anything about your patient on Facebook, etc., etc. All right, so we're going to kind of change gears here and talk about, this is kind of a mixing of two chapters, Chapter 1 and Chapter 2. This is all we're going to touch on Chapter 2 is some cultural considerations. These are some distinguishing factors of ethnic groups. They may have different customs, they may have different food preferences, they may even have different healthcare practices like cupping or coining. Those are all practices that people don't see anything wrong with them because that's part of their culture. They also have very well-defined roles for like who's in charge. Expression of pain. Some cultures are more stoic than others. The foods that promote health, cure illness. Some of the Hispanic population, they feed their babies like some sort of tea. I can't remember. It starts with an M, I think. But some sort of tea to help with colic, even when they're just infants. So lots of different cultural considerations to take into account. Here are some specifics. In the Asian American, family is central. They view life as a cycle. Pain is described by diverse body systems. Health is a balance of yin and yang. In the Arab American population, women are definitely subordinate to men. Young subordinate to old. Family loyalty is primary. Pain is not tolerated very well. Hispanics, the father, of course, is the source of strength. Mom is the nurturer. Food, again, food used for celebrations or medical treatment, socialization, and pain is tolerated very stoically. Here's some components of cultural competence. It'll behoove you to read through those. That's also in the textbook as well. Okay, speaking of the textbook, we're going to flip over here to Chapter 1. And I do want you to go back to page 10 in Chapter 1 and read through the mortality and the morbidity information. Here's the Healthy People 2020, the general health measures. There's kind of 4 focus areas. You can read through that. So start your reading on page 10 versus page 13. There's definition of morbidity again. This is the same graph that was on the slide, but it is a little weirder. So I would go back to the slide if you're going to take information from that slide. All right. It does talk about the trend in the United States increasing number of kids with mental health disorders. Now, I have my own theory on this. I think we are just diagnosing more. For example, autism. The incidence of autism has gone up. Has it really? Or has just the diagnosis of autism increased? ADHD, same thing. The incidence of that has gone up, but I don't know if it's because really the incidence has gone up or if we're just diagnosing it more. So take that. That's a freebie. Won't be a test question. All right, and then this talks about what we focused on the slide, the evolution of pediatric nursing, the philosophy, and the roles. Now, the roles of the pediatric nurse, it's kind of broken down into tasks. Of course, we want to provide culturally focused care, and that's what the information in Chapter 2 is kind of concentrated on. We want to provide care across the health-illness continuum, not just taking care of the sick kiddos or not knowing just how to take care of the sick, but we also want to focus on prevention and safety and things like that to prevent illness or injuries. Here's the biggie: providing family-centered care, providing preventative care, immunizations, screenings, etc. Continuum of care. It's really important for kids to have a health care home. That way we can track their growth and development. You know, if they have a chronic illness, we can manage that. So real important to have a family PCP and stay with that family PCP or with that pediatric PCP. Providing child and family teaching. That will be 50% of your job if you're a pediatric nurse, is to provide that teaching to the family. Participating in research. Again, evidence-based practice, fancy, more appealing name for research, but very important in pediatric nursing. We want to know why we're doing what we're doing. And if what we're doing isn't the most beneficial for the patient, then we need to figure out a better way to do it. So big research areas, evidence-based practice plays a big role in pediatric nursing. There's the good old nursing process. Talks about all 5 steps, and I think we talked about that. All right, assessment. Assessment is always the first step. All right, again, these little take note sections, very, very important. Nurse practice roles in various healthcare settings. You're going to have acute care nurse practitioners. You're going to have primary care nurse practitioners. You're going to have family nurse practitioners that take care of kids as well. So lots of different levels. PAs. We have PAs that work in the emergency department at Cook Children's. I'm sure that we're not the only place, so you'll have a lot of PAs as well. About standard of care, standards of practice. This does give you some information about how you apply the nursing process to our standards of practice. All right, legal and ethical issues, like we talked about. This is where it's going to go into consent, emancipated minors, etc. So let's get down to that part. There's consent, informed consent. Again, remember, you are only witnessing that the patient or the care provider or caregiver understands the consent, understands the process. You can serve as a witness to the signature process. This is a very important little 3-dot set of sentences here. Box 1-1, very important. All right, so here's some exceptions to the parental consent requirement. Okay, emancipation may be considered if any of the following situations are happening. If they're in the Army, if they're married, If they're court, you hear about all these people divorcing their parents and becoming emancipated minors. Well, that's it. If they're financially independent and living apart from parents, if they're pregnant, or mother younger than 18 years of age, if they already have a baby. They can, this is funny. Okay, so if you have a 16-year-old mom and she has a baby, she can sign consent for the baby to be treated, but she can't sign consent for herself to be treated for, say, like an ear infection or strep throat. Now, if she were seeking treatment for a sexually transmitted disease, or if she were pregnant, she could sign her own consent. But if she's 16, has a baby, and has a sore throat, she can't sign her own consent. It's very different. And here's all of that information in a table. Pay attention to all of the little tables and boxes throughout Lippincott. The important information, they highlighted there. Parents can refuse medical treatment. They can be overridden. Legally, it's a big ordeal and situation, but sometimes they can. That each hospital has an ethical committee, I guess, that makes decisions, tough decisions sometimes, about the ethical treatment for kids. For instance, if they have a child on life support and the parents are just insistent that they stay on life support, sometimes that becomes an ethical issue that has to go to the ethics committee, and decisions have to be made whether to withdraw treatment or continue treatment. It's a job I would not want. Here's some more information on assent. Advanced directives. Again, those are applicable in the pediatric setting as well. Here's some information about Hipaa that you could probably recite back to me. And then if you ever notice a chart that, like if you try to access a chart and it brings up the stoplight, some of the patients, if they come in for like sexual abuse or physical abuse, they are confidential patients and no information is leaked out to anybody that's not involved directly in their care. So that's important to remember. All right, and here's your key concepts. We'll read through those, and there's always questions at the end of each chapter, so those are very helpful as well. I'm going to flip over to chapter 2 and just go over the culture information that I assigned. I think it's page 41 through 44. So here's information on components of cultural competence, and this is the same thing that was on the slide earlier. Some information about different cultural groups. Again, the United States is a melting pot, so you're going to encounter most cultures. One thing I do want to talk about that I'm not sure that it addresses here in the text is translation. So if you have a patient that speaks Swahili or something that not a lot of people speak, how are you going to discharge that patient? Okay, you're going to have to find a translator, right? Now, a lot of hospitals have the blue phones. I don't know if you've ever heard of the blue phones that you can call a translator and they will translate into, they have all different languages, and you can relay your questions back and forth through the phone. Some systems are getting really fancy and they have a internet-based translation department, or what am I trying to say, service, that you click on a language and you get an interpreter for that language, and it's kind of like a FaceTime situation, and they can see your patient and your patient can see them, and they can talk back and forth, and then you can interject and add your discharge instructions or ask your questions that you need to do for an assessment, get your history, etc. So it's really kind of handy. Make sure that you do have an interpreter if you have a patient or family that speaks another language that you don't speak. Very important. Legal issues can arise if they aren't properly discharged in the language that they can understand. All right, and then this is the same information, only it goes a little bit, it has some more information about American Indian and Alaska Natives, some beliefs and practices of their culture. All right, and I'll let you just read through those few pages. All right, so that's all I have for this session. You all have a good day.